There isn't one universal clinical name for that specific behavior, but it overlaps with several patterns that researchers and clinicians describe. The behavior you're talking about, using medical crises or ER visits to control a partner's time, shows up in discussions of relationship abuse, factitious behavior, and manipulation. Here's a breakdown based on psychology, domestic abuse research, and medical literature. Terms that get used for this pattern. 1. Coercive control. This is the broadest and most studied framework. Coercive control is a pattern of behaviors that restrict a partner's freedom. Using real or exaggerated emergencies to prevent a boyfriend from seeing friends would be categorized as _isolation_ and _monitoring_. 2. Medicalized manipulation. Emergency is leverage. Clinicians sometimes describe cases where someone uses health crises to gain attention or control. If the person is genuinely sick, it's not manipulation. If they're exaggerating or fabricating symptoms to limit a partner, it falls under _instrumental use of illness_. 3. Factitious disorder imposed on self. DSM-5 defines this as falsifying physical, psychological symptoms without obvious external reward, mainly to assume the sick role. If visits are fabricated and the goal is care, sympathy rather than controlling someone's schedule, this fits. But if the main goal is to control the boyfriend's time, researchers usually call it _secondary gain _. 4. Malingering. Malingering is intentionally producing false, exaggerated symptoms for an external incentive, like avoiding work, getting drugs, or in this case, controlling a partner's availability. The key difference from factitious disorder is the presence of a clear external goal. 5. Emotional blackmail. Darvo in relationships. Susan Forward's work on emotional blackmail covers threats of self-harm or crisis to prevent a partner from acting independently. Darvo equals deny, attack, reverse victim and offender. Some ER-related control tactics show up in abuse case studies. What the data actually says. There's no large-scale dataset tracking people who use visits to stop partners from seeing friends. The behavior sits at the intersection of intimate partner abuse and healthcare use, so we have to piece it together. Intimate partner violence studies. The CDC's NISVS data shows that 1 in 4 women and 1 in 9 men experience contact sexual violence, physical violence, and/or stalking with IPV-related impact. Coercive control is a common tactic, and isolation from friends, family is reported by operator 40% of survivors in multiple surveys. Healthcare utilization. Research in Journal of Interpersonal Violence notes abusers sometimes create medical crises or sabotage healthcare to maintain control. Emergency departments report cases where patients admit the visit was to avoid a partner leaving the house. Factitious disorder prevalence. Estimated at operator 1% in hospital settings, but likely underdiagnosed. Most cases aren't about controlling a partner specifically, they're about the sick role itself. Gender note. These behaviors aren't gender-specific. Studies on coercive control find men and women both use medical crises as tactics. There's no clinical term that applies only to women. Why people might do this. Psychologists point to a few drivers, and they can overlap. Attachment anxiety. Fear of abandonment can lead to extreme tactics to keep a partner close. Control power motives. Part of broader abusive dynamics where the goal is to dominate time and social access. Learned behavior. If crises reliably got caregivers' attention in childhood, the pattern can carry into adult relationships. Secondary gain. The visit creates a legit reason the partner can't leave, avoiding conflict about going out. Important distinctions. 1. Real medical need versus tactic. Some people do have chronic conditions with frequent visits. The diff.